Okay, so super excited to go through this specific talk because it's something that has really been misunderstood in the past. And I think functional medicine really brings a great new perspective. So, as you can see, the title is Understanding Fibromyalgia the Functional Medicine Way. And I'm hoping that we're going to be going through some elements of fibromyalgia that you may never have heard of before. And I also want to show you exactly how we use all the functional medicine questionnaires and handouts along the way. So sit back, relax, just open your mind and start to understand what the fundamentals are. And as I was saying, fibromyalgia is something that's been very misunderstood in the past, and it's almost been something that has been perceived as maybe it doesn't exist, but it certainly does. And as we're learning more about it and understanding from an underlying root cause and the hows and the whys, we're really understanding how different it is to other chronic pain conditions, and that they also have a central focus, but they are different. So let's slowly go bit by bit and start to understand. So, one important aspect is that there is this massive bias towards women in the distribution as far as gender goes in fibromyalgia. And this isn't clearly understood yet, but it is just so important to understand that there is this mass difference. So, if this is part of your niche, this is something that you also need to understand and focus on and go from there. So, in the past, it was a sign and symptom when they came to their primary physician that the primary physician really didn't know what to do. And there was this term out there, and they were a bit confused. And ultimately, they actually started to think that a lot of the women coming to them with all of these, tenderness everywhere and this subtle depression and anxiety and not sleeping properly were a little bit cuckoo. And that was sad. And it's really just a sign of the times of conventional medicine not understanding the depth of where it has come from and how these imbalances have occurred and how it differentiates from other pain conditions and so on. So, yeah, I mean, this has been something that a lot of practitioners have referred patients to psychiatrists and put them onto antipsychotics and psychologists and that type of thing. And that has been the approach a lot of the time for fibromyalgias, these chronic pain syndromes. So one phrase that is being used now that has a lot of worth in it, as we go through this, you'll understand why, is central sensitivity syndromes. And there tend to be this common link towards neuroinflammation. And although they have this common link back to an inflammatory type of situation in neurally, they are all slightly different. And I think that is key, because as we get to understand functional medicine better and better, and there are these different clusters of signs and symptoms which may be given a diagnosis, we still need to understand that they have specific imbalances through different pathways, through different neuronal pathways, metabolic pathways, genetic influences. And understanding that in your specific niche, I think, is fundamental if you're going to be the expert. So that is what we're starting to see, is this massive trend towards neuroinflammatory underlying situations that are fueling a lot of these diagnoses that have been put to all these different clusters of signs and symptoms. And fibromyalgia being one of those in this realm of central sensitivity syndromes. So over the years, there's been many proposed etiologies, and it's really been this process of understanding fibromyalgia and where it's come from and what is the root cause, and is it a virus, is it EBV, Coxsackie, HIV, hepatitis, whatever it is, where has it originated from? And certainly there may be instances where there is a virus, but it's not going to be the bottom line for all fibromyalgia. There's been the cases of neurotransmitters are the issues there, and a lot of the medications have headed in that direction to try and give some relief, and we'll discuss a little bit about that later on. Fibromyalgia has been very much associated with hormonal imbalances, from thyroid, adrenal growth hormone, and so on. And this is, again, something to understand as we go towards a differential diagnosis, to see, is this a fibromyalgia, or is this suboptimal thyroid, or is this an adrenal issue? What is it? And sometimes there is an overlap, but we still need to understand how they differentiate, and that there are different pathways, but they can simulate very similar signs and symptoms. Sleep disorders are going to creep in here fundamentally, and we're going to go through quite a lot of that. But what you have seen with fibromyalgia patients is they have sleeping issues. And this is a fundamental part of fibromyalgia that we're going to discuss. Psychology has been very much implemented with fibromyalgia. And again, we're going to discuss this and how this relates to it. But there's been this connection of, in the past, as far as psychological issues go with fibromyalgia. Neurological as well, sympathetic drive. Is there cervical compression? Is it a nerve issue? What is happening? Is there inflammation in the nerves, in the muscles? Are there nutritional issues? Magnesium, malic acid, something in the mitochondria? What is happening? Is there toxic elements involved here in inhibition? And then looking at certain like pathways in the mitochondria from a metabolic point of view, are there issues there? Is it related to intestinal dysbiosis, and so on? So a lot of thoughts in the past, and I think it's important just to be able to clarify and get clearer on what fibromyalgia is. And the reason for that is there's no specific panel that can help us to say, okay, this is Lyme disease, or, this is a viral issue, or this is leaky gut. Here's the panel to do it. For fibromyalgia, there is no specific panel, no factor test that we can come up with to say, okay, if somebody has fibromyalgia. So it's very much out there for us as clinicians to really understand, and then to put the pieces of that puzzle together. So when we gather information from a functional medicine perspective for these fibromyalgia syndrome type patients, it's important to just get our heads around where to gather things and what to do. And, no doubt that gathering information in functional medicine is going to be the most important. And we're very thorough with that, and we don't want to leave anything out. So I'm really just going to highlight a few things here that are just very important when it comes to fibromyalgia, and that'll point you in the right direction, but you don't want to leave anything out. And certainly what we've found is just getting a subjective assessment from that patient can start to give you a good idea, is it heading in that direction? And one of the big ones is going to be global tenderness. It's not regional, it's not in this specific area, it's not unilateral, it's a very global tenderness, and that pain is associated with all these signs and symptoms as far as that goes. There's often an early life stressor, and we've got to go through back on that timeline and don't discard any situations, and ask the right questions back into teenage years and into, even before teenage years, of how was the family life, because we are seeing these strong associations of adverse childhood experiences, and sometimes it's not something dramatic and specific as a sexual assault or anything, but maybe it's just a very abrupt, hard father that speaks down to their children, and this really affects some really sensitive children. So it can be something more subtle that isn't really picked up as an event as such, but can have major consequences later on. Good to just assess levels of anxiety. Is there mild depression that is popping up? So as we go through those timelines, to have a look, what medications have popped up at what stage? Were there periods of anxiety, depression, because this is all going to feed back to this neuro link with the fibromyalgia, whereas we're always trying to look at where is the muscular skeletal aspect of it. But you're going to see that we need to actually connect it neurologically. So there are these associations with fibromyalgia that tend to pop up. Have they had a history? We'll often hear that somebody's been waking up non-refreshed for 10, 20 years, even though they sleep 12, 14, 16 hours. And this is fundamental, and we'll show you why now. There's often an element of IBS. So there is this gut disruption, and we'll show you the association there as well. So have a look for that in that timeline as we're going through. Do they often have a racing mind and unable to fall asleep? And this, again, from a subjective assessment, is pointing you in a certain direction, because fibromyalgia patients tend to have these cluster of signs and symptoms, not just this generalized pain. When we go into an examination, again, it's going to be important to go through those tender points, and we'll go through there. And specifically, what you want to be looking for is ruling out other conditions. I think that is the important part, is to rule out through that differential diagnosis, are we working with something else, or is this actually a fibromyalgia? And then labs are going to be so important, again, just to help rule out other pathway imbalances, disorders, diseases, whatever it may be. Looking at genetics, on how those genetics can be upregulating certain inflammatory pathways, oxidative stress, detoxification, imbalances, and so on. And again, this is important because we don't have these fibromyalgia panels. So important to not just use the intake forms that we tend to do starting off with our functional medicine patients, as well as your MSQ and your 3-day lifestyle journal, but to look at the depression, anxiety, stress scales as well. So this form is in your toolkit. Use this, because this is going to be fundamental to help you when you've gone through that intake form. This may be an additional one that you then give to them, to then just start to accumulate more information if you have already suspected that this may be a possibility. Go into your sleep questionnaire as well. You want to know, for most patients, you want to know where is their sleep pattern. And if they aren't using a sleep tracker, you want to be starting with the questionnaire and start to see what is popping out there, and that's going to give you some important. Use the HPA axis questionnaire. Very important to find out just subjectively, are they tending towards low cortisol state, elevated cortisol state, or where is the disruption in the HPA axis? And that's going to be, again, a confirmation of, if we do say the Dutch Plus test and we're heading in that direction, to be able to use that as a confirmation with those tests. And then later on, are these signs and symptoms then slowly dissipating, disappearing as they're getting better, as their MSQ drops, and so on. So the differential diagnosis are really going to have to be, the big one's going to be between chronic fatigue syndrome and myofascial pain syndrome with fibromyalgia. And your chronic fatigue syndrome fundamentally doesn't have this generalized pain. Their main issue is going to be fatigued all the time, and it's going to be a different underlying root cause, different metabolic pathways that are affected. Whereas your fibromyalgia patient's always going to have the pain in the generalized global aspect, not regional, like with a myofascial pain syndrome or these other ones that we may go through. You've got to differentiate if there is depression in there. Is it organic depression, anxiety, or is it coming more from the aspects from the fibromyalgia perspective? Is there multiple bursitis, tendinitis, connective tissue disorders, particularly from the autoimmune side? Is there rheumatoid arthritis, polymyalgia? Anything like that that may be popping up is going to be fundamental to differentiate. We want to be thinking about the Lyme and your co-infections, anything viral there, if that is starting to head towards that differential diagnosis, because it's going to lead you away. And your whole treatment plan is going to be completely different. Anemias can present that way, suboptimal thyroid, any of those are going to be an issue moving forward. So it's quite a good idea to get your patients to subjectively mark out exactly where their pain is. And it should come up something like this on the left diagram, compared to that on the right diagram, where they may say, yeah, I have arm and leg pain, but when you get them to do it, it's, right arm and left leg, rather than more bilateral. And these are the typical points with fibromyalgia, all 18, 19 points that should be popping up. So just a good diagram to remember of where those tend to come up. So yeah, these are just now some studies that are coming up, and this one is just about suggesting that although fibromyalgia is a well-known clinical entity, differential diagnosis, when they've done specific studies with physicians, that they've found that they are not very good at understanding the differences between rheumatoid arthritis, fibromyalgia, polymyalgias, and so on. And that can be extremely challenging. So in this study, it basically showed that 34% of patients were diagnosed correctly. So that's telling us 66% were not evaluated correctly. And the problem is those 66% are then given medications that are then going to create more side effects, more issues, more problems, and that is the issue thereafter, is when the majority of the differential diagnoses are becoming a problem as far as misdiagnosis, because that's going to lead a patient towards more side effects, more problems. So yeah, important just studies coming out showing there. Now, what they tried to do was to actually say, okay, for fibromyalgia, we're actually going to say that we don't have to do a physical assessment anymore. We're going to go purely on subjective. And tender points don't need to be a positive for fibromyalgia. So this is something that came in to the diagnosis of fibromyalgia from more than a decade ago as a change. And it really is just a big problem, because what it did is it created confusion with all the doctors, with all the health practitioners, in saying, now we understand most patients are going to be fibromyalgia that come to us with a level of anxiety, depression, some pain, rather than being able to differentiate and understand the underlying root causes, the pathway imbalances, and so on. So this is where a lot of these studies or changes in structure can create a lot of confusion. And we know that health practitioners, particularly at the higher level of physicians whose physical skills have become very poor, has now become a problem in just their differential diagnosis. And then it is the medication stacking and moving on from there. So that has become a big problem there. So these are just some of the medical managements over the years that have been tried and used and gone through there. And, tricyclics have been a big domination for many years. SSRIs, still very commonly used actually, as well as MARs. So the big ones trending in therapy at the moment tend to be, these four. And we're going to go through why they're used, because they are kind of plugging into some of the pathways that are the problem with fibromyalgia, and they're giving some effects, but they're not creating a solution, because the solution is obviously not about just one single pathway. We've got to understand the whole aspect. So those ones in red now at the moment, those are the most common ones being used, and we're going to go through a little bit of those shortly. But certainly, muscle relaxants have been tried in the past with no success, because it's not a muscle problem. We've had all the anti-inflammatories being used, painkillers, dopamine agonists, All of those have been tried in the past as a, let's hope that works, and then realize that doesn't work because it's just not hitting the right pathways. It's not an inflammatory disorder, fundamentally systemically. It is about different pathways. There are underlying root causes of inflammation, oxidative stress, but fundamentally we need to understand the processes here. So there has been this big focus on selective serotonin norepinephrine reuptake inhibitors. And serotonin is fundamental in fibromyalgia, and that's why it has been pushed to a certain point, and it is used more and more with the fibromyalgia patients. However, there is a sensitization that happens, and if we do just remember that whole acronym when it comes to neurotransmitters and hormones of production, transport, sensitization, detoxification, we'll understand why that sensitization becomes an issue with these medications, and that they create more side effects and they don't last that long term, and then we have to increase dosage, and then we're getting the vicious forward feed cycle of side effects. So low dose naltrexone has certainly been in fashion recently and being used for autoimmune conditions, weight loss, fibromyalgia, chronic pain, and for good reason, because it has this attenuation of reducing the inflammatory process, and there is an inflammatory effect with fibromyalgia. However, it's still not getting to the root cause, remembering that inflammation, oxidative stress, and immune dysfunction is part of the funnel towards signs and symptoms, but not the underlying root cause. So that is a process. So we can't just abut processes without dealing with the underlying root causes, which I mentioned a few earlier, that we tend to kind of see as far as adverse childhood experiences. There's stress involved, there's sleep issues, there's lack of exercise, and so on, as well as other pathways we need to deal with before getting to how do we down-regulate inflammation. And we know that we don't have to be doing that purely with medication. We've got other ways of doing that. So this is important to just know that imaging studies have found evidence of neuroinflammation in brains of chronic pain patients. And that was just kind of a given. That's something that we were just waiting for more studies to come to the party for us to understand, yes, a lot of these syndromes that we're seeing as epidemic nowadays we're starting to understand that they've got this root cause back at a neural inflammatory process in the brain. And how this links back to the gut, whether it's the chicken and the egg, we're not 100% sure. It can work both ways, but we're understanding it more and more as we go along. So the fundamental aspect that I'm really trying to get across here is there is the classic fibromyalgia, and then there's going to be your pseudo, and we have to understand the differences because we often have these clusters of signs and symptoms that can be very similar, and perceptions from patients can often throw you off course. So we have to be pretty clear, is this the classic fibromyalgia where they've got all these tenderness areas along with sleep disorders, along with anxiety, along with depression, even if it's mild, and along with some neuroendocrine imbalances and CNS chemistry, which we can check on labs, compared to the pseudo-functional medicine syndromes, such as your organic diseases, your functional disorders, your musculoskeletal disorders, as put into the various blocks here. So yeah, this is tough. It's important to understand the differences, because then your personalized plan is just going to be more precise. You're going to know what to measure and move forward from there. So the classic fibromyalgia is really a central nervous system disorder, and we're going to dig deeper into that so you understand how and why. And fundamentally, it can be diagnosed. I wouldn't say diagnosed, but helped in the differentiation. through EEG disturbances. And it's really about the alpha wave intrusion that is a problem, particularly in the frontal cortex. So that is creating then disturbances in the lack of quality sleep, creating these sleep disorders. And fundamentally, with the sleep disorder comes a sympathetic hyperactivation, and that disturbance is really what's going to be fueling these imbalances then in neurotransmitters like with serotonin, subsequent increases in substance P, which we'll go into, and ultimately produces what we call central allodynia, CNS myalgia, central allodynia, and I'm going to explain that now because these all just link together as we talk about them. So let's go through that. So what exactly are these tender areas and points? And people were always like, no, you've got to fix the muscle. Give me a muscle relaxant, a painkiller, an anti-inflammatory, because it's the muscles that are so sore. That's what's really perceived. It's not about I'm not feeling fantastic. I'm a bit depressed. I'm a bit anxious. I'm not sleeping great. I'm waking up a bit fatigued. That wasn't connected because that's not pain. Pain is what people are really, really upset about, unless it's extreme of any of the other cases. So biopsy studies have shown no tissue specificity. EMG studies show no changes in muscle tone. Drug studies, no benefits, as we know, from non-steroidals, steroids, and so on. And pain studies, patients feel pain at tender points at decreased thresholds when compared to control points. So all over their bodies. So the conclusion is there's no peripheral soft tissue issue that is generating the fibromyalgia syndrome. And that is the fundamental aspect of what they have gone through with all the research to find out where it's all happening. So when we want to understand where is it coming from and what is happening and why are they getting this upregulated pain throughout their body, we have to understand these pathways first from the cortex, thalamus, and the spinal cord, particularly the spinothalamic tract. And that is where the fundamental imbalances are. So the key is to just understand this dorsal horn, and that is where a lot of the medications have aimed at and had this limited success. So tricyclics, all your serotonin and norepinephrine receptor inhibitors have tried to aim at these areas to try and gain some control, but have had limited success over time. And only 25% of subjects generally say they feel better, and then they sensitize, and then they're affected with specific side effects like weight gain, burning pain, grogginess, and so on. So those side effects, obviously, we don't want with patients, and we need to be looking from a functional medicine perspective, how do we get control of these imbalances as quickly as possible? So the key is really to understand the spinal cord is the peripheral brain because it contains both gray and white matter. And these interneurons within that dorsal horn particularly integrate and modify all the incoming sensory input. That's important to understand when you understand what is happening with the dysfunction here. So gray matter of the spinal cord is capable of associative conditioning or learning. So that is a problem when it comes to substance P. And complexity of the cord's interneuronal connections allow for this phenomenon of referred pain to occur through an overflow situation. So this is really the spread of pain to normal tissue by the spillover of what's called substance P. Substance P works in opposition to serotonin, and you're going to see now that with these fibromyalgia patients that serotonin is always suppressed, and substance P then can be overregulated. And substance P should be in balance because it is about not allowing the specific descending anti-nociceptive system to downregulate itself. So the descending antinociceptive system is what regulates our body from desensitizing pain. In other words, if you walk outside and it's all cold, you're going to say, okay, I need to put something else on. Now, if you walked outside with no clothes on, you're going to feel that even more. You're going to put your clothes on, and immediately you're going to feel, I've got clothes on, I'm feeling warmer. Now, in 10, 15 minutes, you're going to lose that whole sensation that you've actually got clothes on and that you were cold. In other words, your body has said, okay, I've dealt with that. I'm now switching off all of those input receptors, input sensory nerves coming through. I'm not giving you more feedback, and that's kind of shut off. Now, what happens with this descending antinociceptive system is it doesn't get shut off because substance P is in overflow, in abundance. And when it's in abundance, it overflows to all the other neurons coming down the pathway, and then that initiates all these other nociceptives that go to all those tender points that we see with fibromyalgia. So fundamentally, what is happening here is we have a dysfunction of the descending antinociceptive system because of these imbalances occurring with serotonin and substance P. So that is seen now as being the major cause of classic fibromyalgia syndrome. And the research is strong in this field now, and it's just understanding what has happened. That unfortunately doesn't solve things for us. We're just understanding how it's all happening. And when you have a niche, the key is to understand those pathways, and then you've got to start working backwards to say, okay, so if substance P is high, serotonin is down, now why is that happening? And then we need to go to the underlying root causes, the hows and the whys. So these are just more kind of pictures of the pain of with this dysfunction of the dance, as we call it, and just showing you this overactivity in that particular area of the brain, which is associated to pain and the nociceptors and the spinothalamic tract and so on. So ultimately, this is really what we're talking about, and it's all controlled with the limbic system through the hypothalamus, down through the periaqueductal gray matter, through the nucleus raphe magnus to the spinal cord. The limbic system is the emotional brain. It can block pain for us or facilitate. And so fundamentally, that whole system has become dysfunctional with these patients. And it ultimately dampens the dance. So it's dysfunctional, that dance. It's just not working like it should. Some patients are going to be extreme, others not so extreme. And we need to figure out now, how do we create rebalance with those? So that limbic system is just so fundamental. So it all comes back to being a brain problem of some sorts. And we've got to understand that in more detail as we work through this. So there's strong evidence of serotonin deficiency in the fibromyalgia patients, and we can see this pretty easily with a lot of the organic acid tests that we do, just looking at the 5-hydroxyindoleacetate, so that's the decreased 5-HRAA. Tryptophan is often at a low level. We do see increase in substance P, particularly in the CSF. You can see it also in plasma. You can see it. You see serotonin decrease in the serum and the platelets too. So those are just some aspects that we're seeing with the fibromyalgia patients. So serotonin appears to be the key neurotransmitter involved, not just in the fibromyalgia syndrome as such, but again with this associated sleep issues and this mild depression, and then a link towards the anxiety. And it's really because it drives three major functions. It drives the hypothalamus and the HPA axis. It alters substance P levels and pain, because as they decrease, substance P can go up. And then it Serotonin is fundamental in initiating particularly deep stage 4 sleep. So if we can't get to the deep stage 4 sleep, we're staying in that alpha situation, and that's where the EEGs have seen this alpha wave intrusion, that's called. So we'll dig a little bit into that. So let me go back there. So this is this forward feeding loop that we tend to see. You've got pain, you have poorer sleep, you've got more fatigue, you've got more stress, it gives you more pain, and it's all fundamentally around increased catecholamines, reduction in serotonin, increase in substance P, and we now have to figure out, okay, where are the imbalances coming from those situations? So while sleep studies cannot serve as a diagnostic test for chronic fatigue syndrome and fibromyalgia by themselves, the presence of objective quantifiable abnormalities of these tests can assist us as practitioners by adding to the subjective criteria currently employed to defining these syndromes. So this is just so important because you're going to see these specific problems happening, and what we're finding with our patients is we can use sleep trackers to start to look at the percentages of that stage 4 deep sleep, as well as looking at your light sleep, which is N1 and N2, and then your REM sleep, and looking at those percentages over time while we implement our interventions can be one way for us to understand, are we getting our patients back in the right direction or not? So that's what these studies, just from a more precise situation, are kind of telling us when they're using EEG. Now, we can't be doing EEG on our patients every day. We can do it, maybe once a year or whatever it may be. If you don't have access to that, we've got to think out the box. We've got to think differently. But what it does is it allows us to understand the patient more and what they have found, and that can move us on to getting these patients better. So what are the sleep dysfunctions with these fibromyalgia patients about? And basically, it's about just their non-restorative sleep being the major problem. So what it is the alpha wave intrusion is found during the non-REM delta wave sleep. Now, that may sound all gobbledygook, but basically we should be going from alpha wave into theta into delta into theta. Now, REM should be, once you've gone from alpha, which is last thing at night when you're starting to relax, alpha should then go into REM. And the problem is alpha starts to intrude into the REM, and then we just never get a deep sleep. So we're kind of in and out of sleep the whole time. So we relax, but we never go into a deep restorative sleep. And the problem that they're seeing is that a lot of the delta activity in the frontal lobes is the biggest problem. So frontal lobes is our connection area, is our ability to focus and concentrate in these frontal lobes. And there's a hypoactivity there during the waking state. And this is what's being called the fibro fog. So not the brain fog, fibro fog during the day, because they're not sleeping properly and they've got this depression and anxiety, and fundamentally there's just not this sync when it comes to the frontal lobe, and that's interfering then at night because we're not going from one extreme to the next. It's just limbering in between. So let's go a little bit into the sleep if you guys just want to understand that more. So REM, which is rapid eye movement, is essential part for re-energizing our mind and our body, and it makes an important contributor to our sleep. So REM is associated with dreaming, memory consolidation, learning, creativity, should make up anywhere from 5 to 15%, and typically on average will count from 20 to 25%. So ideally for, say, an 8-hour night sleep, it should be about 1.5 to 2 hours of total sleep for anybody. And it's going to decrease with age, unless it's a functional medicine patient and you've got them on maintenance. Then we're going to be seeing that it stays at good levels and improves. So this is what we're seeing with our patients, is when you can get them rebalanced out of their signs and symptoms, you're working with them in maintenance, then we can start to actually monitor these percentages in the long term and look for trends where all of these start to get better. So that is key. So now let's go to light sleep. Light sleep should make up 50% of the total time. It consists of N1 and N2 stages, which just goes deeper towards going into the deep sleep. And typically most light sleep is the N2 part, which is a deeper sleep. Now we're assuming with the fibromyalgia patients, they're actually having a dominance of N1. It's quite difficult with the sleep trackers to be able to differentiate N1 and N2, and often they will bring those together. So that kind of detail that you're getting back on those sleep trackers is usually a combination of N1 and N2. So we've just got to look at that specifically with the situation of not having the ability to get that much detail. Now, deep sleep, this is a great one to track with these patients, particularly because they're often starting with a very small percentage. And if we can get them more and more into this deep sleep with all the tricks that we have and the understanding of all their labs, then you're going to see the results. You're going to see less pain. You're going to see their moods improve. They're not going to have the anxiety, and they're going to lead normal lives again. So deep sleep is the key. So typically we're seeing on average adults should be 15 to 20%. What we're seeing with the fibromyalgia patients, they can have 0 to 5%. And the key is really just what can we do to slowly get that. Now the great thing is you can test this on a daily basis. And you can use this as positive reinforcement when they start to see even a 1% change at night. You can use that as a motivator for them to get things right during the day, that their sleep's better at night. And we're going to go through a few things that we do use with these patients. So these are just more studies of the waking brain and understanding how this affects the musculoskeletal pain and fatigue in fibromyalgia syndrome patients. And it's just showing just that this alpha wave is a big problem with the conversion down towards theta and delta, that we're not getting that ability to move in the direction of delta. And a lot of it has got to do with these serotonin levels, because serotonin will drive you down to delta. And when it's imbalanced, and remembering that a lot of serotonin issues are going to come from gut imbalances. So we're going to need to look with all our fibromyalgia patients back to the gut and see what is the association there. So one of the big problems is this first world with so much sensory activity, so much information out there. We're on the screens day in and day out. And one of the big problems, this won't be anything new to you, is just nighttime exposure to artificial light. So particularly with these patients, they've got to be super, super aware that this is a massive issue for them, not to allow them to go from alpha right down to our delta waves. And they've got to do whatever they can to get that. So, one easy thing to do is wear your amber glasses, wear your blue blockers. So that's just like really simple, but I think we need to be thinking a bit deeper than that. The research is strong when it comes to the amber lens group, and the studies are strong with that. So that's great. They got to spend a few dollars, they got to wear that at night and get moving. But I think we need to go a bit deeper than that. So we've got to go down this rabbit hole, and we've not just got to look at the blue light emission, we've got to look at other things. So there are studies showing that using dim light at night is actually even more effective than the amber lights, than the amber goggles, but use both. So that would be great, rather than doing bright light, use your goggles plus dim lights and just get them into that peaceful state, and then we can look at what else to do. And you can just get down to the absolute basics, get to bed before 10 o'clock, try and get 8-9 hours of good sleep. Just staying in bed, just staying in bed is probably the first good rule. Then you got to try and sleep for those 8-9 hours. That's the next one. Get rid of all the electronics. Get your bedrooms as dark as you can. And we've got all those tips there. Don't have a TV in your room. They say that a bedroom is only for two things. One is sleeping, you'll work out the other. You can use it for prayer, obviously, and progressive relaxation, but the main thing should be sleep and the other thing, that's it. So we've got some good handouts for you in the toolkit there to go through. And the key is to personalize this with each patient. Sit down with them, find out where their issues are, what can you do to help them. Don't give them the sheets and say, go through it. They're already fatigued, they're depressed, they don't want to do that. You need to pick out 2 or 3 things for them to focus on. And then through your programs while supporting them, you're going to see where they're at. Have they fulfilled them? Are they ready to move on to maybe 1 or 2 more if need be? And that you've got to just positively reinforce all the time. So this is a great handout that is just split up before bedtime, getting ready to sleep, and then sleep time, and going through the 3 different ones there so you can read those and go through it. But they really are fundamental. Don't jump on the bicycle and do a flat out session. Most of these patients won't be able to do that. Don't have a heavy meal and then go to bed. Don't have 500 milligrams of espresso before bed. Those are real basics, but it's nice just to kind of split it up. This is what you got to start to think about before bedtime. This is now getting ready to bed. Let's start to do these things. Have your quiet hour. Listen to some gentle music, do your meditation, do your prayers, and then sleep time. You want to make sure that bedroom is like really, really dark. There's no lights that are distracting. There's no noises. There's all the right environment to sleep really, really well. So let's get back to some biochemistry again and just look at the serotonin. So, this is fundamental, but what I want to emphasize here is just, coming from tryptophan through to 5-HTP and moving towards the serotonin. So the key is with supplementation, we prefer 5-HTP rather than tryptophan or tyrosine because they can move down other pathways of quinolinic acid and picolinate and so on if there is an inflammatory process, and often the 99% of the time is going to be an inflammatory process. So understanding these pathways is fundamental, and understanding where the 5-hydroxyindoleacetic acid comes in as a metabolite through that pathway is important because that's what you're measuring in your organic acid labs as well. So just understanding where that comes through from there. So this is just re-emphasis again. Serotonin and substance P, they work together when serotonin is at a low level there. And we don't have the precursors because tryptophan is being pushed down inflammatory pathways towards quinolinic acid, picolinic acid, kynurenate, like we're mentioning, which you can measure on organic acids. There's no substrate to build that up. And then substance P is going to take over, and that gives you your overflow through those neuronal pathways, creating a dysfunction of the descending inhibitory nociceptive system. So that is really what we're trying to show you here on this slide, is a normal balance and then the imbalance that can occur when we do have this drop in serotonin levels. Substance P is going to rise, and then that's going to create this dampening effect through the limbic system to the descending inhibitory system. So what can we do to just modulate serotonin, increase it? So 5-HTP is obviously going to be your element of choice there, and I'll go through exactly why and how to do that. Melatonin may be very necessary for these patients as well to get them to sleep properly. And ultimately, we want to try and reduce and eliminate antidepressants and medications, tricyclics, SSRIs, SSNRs, MAOIs, etc. So if we're not reliant on them, we can actually get the body's pathways working properly with the proper feedback systems and so on. So we're not creating this desensitization because we've got one element coming in. They're not modulators, they're inhibitors. Stress and anxiety management, so key. So fundamentally what you're going to find with fibromyalgia patients is they have an upregulation of catecholamines. Their epinephrine is super high, and this is why they have the racing mind at night. They can't fall asleep. There isn't this ability to dampen that system either. So we have to go through, because these pathways can then just be reinforced, we have to look at how do we help them manage the stress and anxiety. And this falls in very well with us wanting to just calm their whole system down for sleeping and so on. But there are good supplementations as well. So not just using biofeedback, guided imagery, prayer, meditation, yoga, and all of that, which we've got many handouts that you can use. I'm going to go through those now. But you can use your GABA and L-theanine and your inositol and your calming adaptogenic botanicals. And we'll go through the list of those. There's a lot of good nutritional supplements you can use, and there's some very good magnesiums that can calm the systems down. There's some very good CBD supplements that can also help calm the system down for nighttime. So that is key. So just getting back to 5-HTP, there's a lot of good studies on just showing that between 100 to 400 milligrams per day can be fundamental to just help those serotonin levels, help to drive them into that deeper state of sleep. And often these 5-HTPs need to be split up during the day. So you could be doing 100 milligrams 3 times a day and just slowly getting it into the system, not doing just one big dose. We want it throughout the day. Some patients may go right up to 400 milligrams a day, so you may need an extra dose. But that's what we generally find is working. So anywhere between 100 to 300, max 400 milligrams. Working well. So this you're going to see on your organic acids. So 5-hydroxyindolyl acetate, that is your urine metabolite of serotonin. And here you're going to see that it's at a very low level. And this is often associated with depression, with insomnia. So that is fundamental to understand there. If it is super elevated, you need to find out, are they already on HTP? Are they having tryptophan supplements? Are they on SSRIs? And so on. So that may be at the other end that is happening. So for you to understand those pathways, to get a good intake, know what they're on, and then to know, because that's not the only thing that is going to work for them. We've got to look at other factors as well and why that's been disrupted. So those are just your dosages. Melatonin, a good guideline there. Some patients only need 1 milligram, half a milligram of melatonin. Others need 20 milligrams. So you need to just tighten that up and find what works for everybody. Melatonin you can also use up to 3 to 6 hours before going to bed to start to initiate that whole cascade of neurotransmitters. So you can start with very low doses 3 to 6 hours before, and you find out what works for that patient. So that can be very effective as well. And sometimes that's more effective than taking a big dose as you go to bed, is taking a very small dose a few hours before. Now, very important that their vitamin D levels are at the right level. And the reason for that is that vitamin D activates the transcription of the serotonin synthesizing gene, tryptophan hydroxylase 2, in the brain. So that is just so important. I mean, all patients, we need to have the vitamin D, but for fibromyalgia patients, even more important because we need those serotonin levels upregulated there. So I'm not going into much depth here on the gut because you guys should know that from your other webinars and just understanding why. But yeah, we have to be looking at the gut from the serotonin point of view as well, and it often is a big gut dysbiosis there. So here's some sleep formulations that promote good sleep. So from melatonin, as we've spoken about, GABA, GABA, you need to be using that in a different way rather than regular. So what we often find works is using it 5 days, 2 days off. You can do that for 2 weeks. Then you need to have a full week off. You can do that for 2 months, and then you need to have a full month off. So GABA, again, if you're just taking that straight off all the time, it's going to sensitize. Your body's not going to produce its own GABA, and we're going to have a problem in the long term of reliance there, and you're going to need to use more and more and more. So you need to use that sporadically, and we suggest the 5-2, 5 days on, 2 days off. Do that for 2 weeks on, 1 week off, and then you can do that for 2 months in that cycle, and then you have 1 full month off. Chamomile can be fantastic for a lot of patients. L-theanine, which is your precursor to GABA, that can be used continuously because it will decide which pathways it's going down, and it's a rate limiting factor. It's not the pure GABA. Inositol can be a life changer, and I've seen patients that one last supplement has been what's turned them around with their anxiety and their depression and their fibromyalgia. So don't ignore that. That can be a complete game changer. So this is just re-emphasis with the racing mind that they tend to have, is they have this upregulation of catecholamines. It's a heightened sympathetic reaction. It's part of this alpha wave, beta wave, and the alpha wave, just staying where it is and not allowing the body to move into the theta and the delta. So we need to be thinking about that. Homovanillate, when it is high, when it's super high, it can be a neuroblastic tumor, just something to think about. But when it's at these levels, it's more than likely, if associated with all the fibromyalgia signs and symptoms, it's just part of that process of confirming this upregulation of dopamine and epinephrine. So when we look at PTSDs, we look at any trauma, whether it's been a single event, whether it's been multiple events, whether it has just been events that have been dramatic enough to affect that person, it doesn't matter. The bottom line is everybody perceives things differently. And for them, if that's a stressor and that's upregulating their epinephrine, their catecholamine secretion, we need to be aware of that if they are particularly coming to you, in the situation with all these signs and symptoms over a period of time. We need to understand that that is part of what we have to help them with and deal with, because one mechanism between fibromyalgia and you helping them to feel better is going to be the sustained fight and flight state that a lot of them are in. Now, their cortisol levels are often flat and finished off, but they have this ability to just stay in this fight and flight. And we know that's not good. So that is one reason their serotonin levels are so poor and down, and why this dampening effect of the descending inhibitory nociceptive system has happened. So the whole system dysfunction can be called stress-induced allodynia. And I'm not going to go, I think you're understanding that. I'm trying to get that point across. What has happened here? So there is this fundamental link to a psychological situation, and that is probably why in the past a lot of those patients who were sent to psychologists and psychiatrists, because they did have a history in their timeline of some kind of stressor that needed to be dealt with, but that's not what's going to fix them completely. You do need to look at them from a complete functional medicine perspective. So dopamine goes up, melatonin goes down. Phosphatidylserine can be fundamental just to help blunt the whole ACT cortisol response to physical stress. So remember that as one of your go-tos as you see these high numbers in the organic acids of homovanillate and vandylmalate. So these are your calming adrenal botanicals: ashwagandha, chamomile, valerian root, passion flower, lemon balm, and they'll often be put into a complex, so you don't have to buy them individually. You just need to look for the right one, and they can be really, really powerful as far as that goes. We never want to rely on that. We want to look at other things. So just to remember, whatever that patient is thinking about, they're going to be creating feelings. Those feelings are going to create behaviors, and those behaviors will reinforce those thoughts. So what can we do to intervene in this whole process so they don't have this push forward cycle just in their thinking process? I'm never going to get better. This is just something that's going to be with me forever. And those thoughts reinforce this pain condition and keep disrupting their hormones, their gut, and everything else. So we've got to just look at all the strategies for transforming stress. Now, you've got some great handouts to go through and look for that patient, what would work for them. And sometimes just getting them into some social events that aren't too taxing to begin with may be, fundamental for them. Getting them to go for a walk each day, helping them to start to journal and just write down what they're grateful for, and start to turn that difficult day into focusing on what's really good. They're alive, they're breathing, that can be fundamental. So think about how you can help them. A lot of us want to go towards interventions, and that's great, and using biofeedback. I think that's very good nowadays. We need to use all of that. And there's a lot of these heart maths that we can use. There's the aura ring that you can see on the right side. So all of these can be used at home, and they can be really powerful. We use the aura ring app quite a lot. And here you can actually see, this is a graph of a patient that we pulled there, of just a subtle trend over a 10-day period between heart rate variability and deep sleep time, and how that slowly changed over 10 days. And that's actually pretty dramatic. You see changes like that in 10 days, like you're in the right direction. So that is very positive. We often see quite a wave and then an overall trend over a period of time. So a 10-day period of kind of constant up there, that's pretty solid. And then there'll be a little dip, and then you've got to move that curve up and keep monitoring. So yeah, that is powerful, and there's a lot of good technology. We've got to use that all the time. So meditation alleviates fibromyalgia symptoms in women. Great study that just supports that. We know how powerful meditation is in reducing inflammation, in just rebuilding the brain, changing the brain. So it's something we've got to use. Forgiveness education. So sometimes I'll just get my patients to read the book. It's called Letting Go by Dr. Hawkins. Powerful book to just go through and understand how easy it is just to let go certain energies, certain situations that you haven't let go for a decade or two, and that'll just keep driving those catecholamines up, and that serotonin down, and substance P up, and so on. So yeah, that can be fundamental, just learning how to let go emotions, forgive. So have a look at that book, Letting Go by Dr. Hawkins. That is a powerful book as well. So what are we going? Just through a quick review. A lot of this comes back down to, although we're working with fibromyalgia, fiber in muscle pain, a lot of it's coming down to the nerves, the brains, the descending pathways, imbalances between serotonin, substance P, catecholamine overactivation, delta waves in the brain just not happening for these patients. We've got to get them into that deeper state of sleep, and we've got to bring all our tricks out there to be able to help and facilitate this process. So fibromyalgia on the whole is, as I've just gone through here, about that limbic activation and normalization again. So that we don't have this HPA activation, we have a normal functioning descending antinociceptive system. We got central sensitization, not central sensitivity syndrome. Our substance P is where it should be and doing what it should be doing. We don't have synaptic excitation. We've just got good balance. So that is really what we're aiming to do from a neurological perspective for these patients and how they're different to other patients. So which treatments seem to help classic functional medicine syndrome patients? And this is really just coming down to from meta-analysis with a lot of studies. So there is a strong evidence of just mild aerobic exercise and gentle stretching, not CrossFit, not high intensity, mild aerobic exercise. And exercise has been found to be just so powerful to change a lot of hormones, neurotransmitters, down-regulate pain pathways, and so on. Cognitive behavioral therapies, and that's going to come down to forgiveness education, meditation, all of those factors to just get our brains thinking in a more positive way. And there's a lot of research showing how that is instrumental in just getting rebalancing of inflammation, oxidative stress, and immune. Sleep hygiene therapy, powerful as well. We need to understand that. We need to get that right. Patient that sleeps well is going to feel well. And then how do we use low dosage antidepressant medications when needed, and just to jumpstart those patients? And then what can we replace those with in the long term with supplementations and the right things so that we can eliminate those medications in the long term? But there's a lot of meta-analysis on those, working pretty well. So this is just a quick summary of all of that I've gone through there. I'm not going to dig deeper into that. The real key is to just identify all those imposters of fibromyalgia syndrome. So if this is part of your niche, your understanding, you're going to get patients coming in with this no matter where your area of expertise is, and you need to have some fundamental understanding on how to help him. But the big imposters are going to be your suboptimal thyroid function. And thyroid is so secondary to everything, so you need to understand that because it can mimic a lot of what we see with these FMS patients. Myofascial pain syndrome can be a big one. Suboptimal mitochondrial problems, energy metabolism problems. And you're going to pick that up on your organic acids, where you're going to see these issues coming through. Now you can have these overlaps, and that's where your clinical skills are going to be challenged. So these are some therapeutic, nutritional, and herbal strategies for muscle tightness and spasm. You probably know a lot of these, so I just want to put these in so you're aware of those. And sometimes you can use these in the short term just to help that patient get out of get some temporary relief, get out of that pain cycle, and then you can just back off from it. It's not something you've got to stick with for a long period of time. Mitochondrial support, these are the general supplements that we've seen work really, really well. And again, you may need them as a boost initially, and then you can back off once everything is working again. So this is, again, just an algorithm working through all of that. I'm not going to go through this now. So yeah, I mean, it's really taking you from here and taking where we were in conventional medicine thinking through this frustration and not knowing what to do, and what are these patients coming to me with these silly situations, and ending up being happy that your patient is not just hugging you, but you feeling, okay, I'm in the right direction. This is giving me a big boost, and that is massive. So that's the way we want you to be feeling when you do have these patients coming across, you understanding them deeper and better. And I hope I've just given you a bit better insight into what is possible with those fibromyalgia patients, and the fact that you just understand them deeper at this point.